59 years old, male, epigastric pain last year. CT scan showed a pancreatic cyst, and MRI and EUS with IPMN with suspicion of intracystic nodule of 4 millimeters.
Do they know? No.
Now a EUS with sonoview and maybe FNA.
So I'm just trying to face the lesion. I'm now in the head of the pancreas. So this is a very nice location because we can see here the SMA. We can just torque a little bit, and we start to see the head of the pancreas. And right in front of the image, in the top of the image, we have the lesion that we are trying to evaluate. Okay, so this is quite a complex lesion. We see much more than you have seen in the slides, because it's not only the image of the lesion that we have right on top, but there's some additional issues, some other small cystic lesions very close to this one. So this seems to be really a mucinous lesions, as we know from the past. But it's much more complex than what we expected, just to see a small lesion. So really we will need to work a little bit in this to try to increase our diagnostic capabilities to really find out what exactly we are working with.
So the pancreatic duct seems to be not related, seems to be normal.
Yes, in fact, we can go to see, because this is also a very nice image, to see how we can see the lesion from the stomach, because we start to see the lesion from the stomach. And in these cases, whenever you have a cystic lesion, it's very important to take a look at the pancreas to see how the pancreas look like, because if you see changes of chronic pancreatitis, it can give you some information regarding the further diagnosis. So now we are in the pancreas. This is the body of the pancreas. So Mara, you can show us, this is the body, the splenic vein, the confluence with the portal vein and the superior mesenteric vein. And we can very nicely see below the portal vein one of the cystic lesion, probably the one that you saw, but you can see close to this lesion that we have some additional ones. We can see them here. So the this is quite complex. At least we have one lesion there. We have another lesion. So,
and this is the pancreatic duct?
Yes, I think, yeah.
This one?
So it seems that the pancreatic duct, it seems that the lesion is connected with by a side branch to the main pancreatic duct. So probably the diagnosis of an IPMN can be an option. And maybe when you have two lesions close to each other but separated, it's more related to an IPMN, less to a mucinous adenoma or even an inflammatory retention cyst. So I think we're going again to the head of the pancreas, because this is a good indication to perform a sonoview to see how is the behavior after the injection of contrast of the lesion.
If this patient has a cyst with nodule, and it's a large cyst, you can say that this patient needs a surgery.
Well,
there were some features.
The
size of the cyst and the nodule. So,
Mara is showing you that we have the nodule.
This patient.
At the end it depends. If, as Mark is highlighting in the back, if you have a nodule that is bigger than 10 millimeters, I think there is an indication for surgery for sure, because this is high-risk stigmata data, and that needs to be an indication for resection. Between 5 and 9 millimeters, you need to take into account the age of the patient, the comorbidities, the type of surgery that needs to be performed, and of course, the opinion of the patient.
But if there will be any enhancement at sonoview, for sure the patient will go for surgery?
If it's enhancement in my hospital, even over 5 millimeters with enhancement, we will, in a patient below 60 years of age, we will discuss to propose the surgery in these cases.
You want these sonoview?
Okay. Okay.
You can see the...
we can almost see the nodule in the...
Sonoview is going in.
Okay.
Just so you know.
So now we
Okay.
see that the Sonoview is getting into the vessels. We are now in the first 30 seconds in the arterial phase. Okay, so now we have here the lesion in the part of the Sonoview, and here we can see in this part of the image the node that is very difficult to see after we increase with the low mechanical index, and I can say that it's a very, very slight. It's difficult to see that it's really an enhancement.
So maybe it's some mucus.
Probably, according to this Sonoview image, I will go for just mucus because I do not really see the enhancement of the nodule.
Yeah, I agree.
So now we've just in the venous phase, and there is still no. It's clearly an avascular lesion with no uptake. There's no also enlarged on the wall. So there is probably that is not really a nodule. It's more a plug of mucin inside of the cystic lesion.
Okay.
Now the point is, should we biopsy it or not? I'm trying to make the question to myself. Because I think in this lesion in a 59-year-old woman, although we have we always can think on increase our diagnostic capability by doing an FNA,
Yeah.
and even trying to target that nodule that we've seen in the B-mode imaging.
I would say yes.
Me too. But this is a big discussion when after making Sonoview, and this is one of the questions. Okay, you do Sonoview, you see no enhancement, but you still want to make a biopsy. So I think this complementary information that we obtain, and sometimes we do the FNA just to be sure in a young patient that we want to establish indication for surgery or not.
Yes.
Probably if we were speaking about an 80 to 85-year-old patient, even we will just skip, just with the Sonoview, no enhancement, we will skip FNA. But probably in a young patient that we might think on doing a surgery, it might be not a bad option to make an FNA with a 25-gauge needle. And of course, the idea is to try to target the nodule always.
How about prophylactic antibiotic shot?
That's a good question. I mean, we always use antibiotics, but there's also some data in the literature saying that there is not really increasing the risk of infection even if you do not give antibiotics. We do it as a routine in Santiago. Whenever we make a biopsy of a cystic lesion, we give antibiotics. We used to give ciprofloxacin. But according to the data that we have available today in the literature, it's not clear whether it's necessary or not. But since the guidelines said that it's better, we used to go for antibiotics. So now we have here the lesion. We need to be aware that this thing that we have below is the portal vein, so it's better not to go to the portal vein. So what I always recommend in this case is if you're going to make a biopsy of a lesion and you see some nodule, please go to target the nodule. I mean, the idea of this FNA is not to obtain liquid because it's already been evaluated. It's just to target and to try to get a sample from the nodule. So we are going to use a 25-gauge needle because it's the easiest one to target these very small lesions. Okay. Oh.
Angèle, tu veux venir tenir la tête, elle pousse. Au moment où il rentre dans la...
Patient is coughing a little bit. We'll just wait for a second.
Julio, for this small nodule, you prefer the slow pull technique or the suction?
Honestly, I almost never use the slow pull technique.
Oh,
I think I always use standard suction because, in my experience, I have no improvement in the overall accuracy of the technique. Honestly, at the end, according to all of the data in the literature, it doesn't matter if you use suction, slow pull, no suction. The point that the good thing is to put the needle in the lesion and to train your pathologist. But it's a very common question whether to use a stylet, yes or no, suction, yes or no, slow pull, yes or no. But all of the data in the literature trying to attempt, you know, there is a very nice Japanese group that is the high suction group that they use 50 to 100 cc's of suction. And there's a specific group in Japan working in that line. But the results at the end, it doesn't change. The key point is to have a good pathologist.
Okay.
On a 5 minutes de retard. On est en retard.
Okay.
It's okay, it's okay, it's
Okay.
okay.
So we will try to find the lesion again. Okay.
Okay.
So here we are.
Yes.
Yes, but when we give the contrast, it was not. Okay. It's quite hard. Okay.
Yeah, he moved.
Yeah,
Yeah.
he's moving. He's
It's
moving.
moving.
You have a nice. Yeah.
Je vais aller
Very nice.
là. Attends.
This is the kebab technique, hein? There's a brochette.
So this is also provides a lot of information regarding the. Okay.
The dancing nodule.
Yes, so that is more related to mucin. So we will just try to improve.
Better than contrast. Yes. Finally.
Non, maintenant on a fini.
Okay.
Okay, so we're really now inside, and it's really moving, and it's just.
On va passer
This
là.
is more linked just to a plug of mucin. So I think it's, as Mark says, it's even better image than what we obtained with the Sonoview.
Yes.
Okay, but you see how it moves when I just push it, it almost disappears, like making a flat. So this is very, and we're obtaining some liquid. So I think we've, so as any, I think we just, it's okay. Okay.
Il y a du liquide qui remonte.
I mean, it's almost, you see that with the 25 Gods after the puncture, the lesion is almost gone. So, okay.
I think it's interesting to see if you have some mucin in the specimen, huh? Just to, and after we will move for
So can we-
the next case. Can you focus the camera on the, yes.
So this is also important
Yeah.
whenever you manage the sample, it's like mucin because it's like
Jelly, but here
it's not absolutely liquid. It's somehow it.
Okay, but there is a sample here, no? Here?
Ah.
Yes, here. We have a tissue.
So
Okay,
we've
it's
also
good.
get
Okay.
tissue.
Perfect.